Greetings to everyone from India. I am glad and honored to meet all of you through this virtual platform created for the first annual conference of SRIHER 2021. I am Dr.Priya, here to share some facts and knowledge related to early childhood caries. Interestingly, this presentation is about one parameter which may be used as a diagnostic criteria to assess the oral health status of a child, like a proper and a functional stomatognathia system, and differentiate it from a dysfunctional one due to ECC or other factors. The parameter in discussion today is maximum voluntary bite force, or simply bite force, which is defined as the capacity of the mandibular elevation muscles to perform a maximum force of lower teeth against the upper teeth under favourable conditions. In simple terms, the force between the maxillary and mandibular teeth when clenched to the maximum. The measure of these forces, either the balance or the imbalances between them, created within the oral cavity, can serve as a good indicator of the functionality. The measure of these balanced forces, such as maximum bite force or maximum voluntary bite force, or simply bite force, and its dispersion, when enhanced, could be an index to assess the level of normality or deviation from normal in dental health, thereby serving a very important clinical significance. Due to the wide range of reported values recorded in children, using again a wide range of devices and methods, there arises a need to better understand the system and evaluate the reported evidence. A systematic search was carried out to compile data. The inclusion criteria for this review were children between the ages of 3 and 6, with the outcome of interest being bite force measurement. The study designs included observational and experimental studies. A systematic search was carried out using keywords across 4 databases. Data extraction for the included studies were done by 2 independent reviewers, followed by risk of bias assessment for the included studies, again by 2 independent reviewers. At any stage, if there was a discrepancy, a 3rd reviewer was sought for consensus and expertise. The results were subjected to statistical analysis. The search across the 4 databases with the key terms led to a total of 603 studies. After the removal of duplicates and exclusion of the studies that did not match the inclusion criteria, we narrowed down to a total of 12 studies which assessed the bite force in children between the ages of 3 and 6. The 12 studies were subjected to meta-analysis using the random effects model. Gender, that is, bite force values of the males and females, were subjected to meta-analysis. And a comparison for the right and left sides were also done. The final bite force value averaged to 246.22 newtons, ranging between 220 to 274 newtons. This value was recorded from 1,932 children who were included in this review. Among them, there were 751 boys and 758 girls. The boys had a slightly higher value of bite force of 222 than that of the girls. Also, a comparison between the right and left side showed no major differences, and the right side had 169 newtons, while the left side bite force averaged to 163.88 newtons. To conclude, there were 7 different devices that were used to assess bite force. Among them, the portable occlusive bite force gauge was the most commonly used. This might be because of its ease of use, portability, comfortable biting element, and instant display of the bite force values. It is also important to assess the role of confounders like height, weight, role of basal metabolic index, and occlusion on the bite force measurements. Clinical trials to assess pre and post-treatment values are required to better understand the role of early childhood caries and its impact on quality of life. With that, I conclude my presentation for today. Thank you for your patient listening.